Welcome to the NSCP module, Standards of Practice Drug Therapy for the Treatment of Opioid Use Disorder. My name is Anik Kamo, and I'm the Pharmacy Practice Assistant Manager at the Nova Scotia College of Pharmacists. This module was created to help understand some of the updates to the new Standards of Practice. It should not replace a thorough reading of the entire document, however. If your pharmacy currently provides or intends to provide this service, please ensure that you review the updated document in full to ensure that you're practicing in accordance with these standards. As with all standards, these outline the minimum expected responsibilities for pharmacy practitioners and are designed to ensure the safe and effective delivery of opioid agonist therapy, referred to as OAT, for the remainder of this module. Before we begin, I would like to take a moment to briefly discuss the process behind the development of these standards, as well as other work we do here at the NSCP. As you know, the NSCP is responsible for regulating pharmacy practitioners and the community pharmacies in Nova Scotia where they work. We consistently evaluate the necessity to update or create new policies and standards, taking into account evolving best practices, public needs and expectations, shifts in our healthcare system, and changes in our practice environment. There are several factors the Pharmacy Practice Department uses to decide what will be included in our work plan. Some of these include insights and ideas shared with our inspectors during discussions with pharmacists. The COVID-19 pandemic significantly transformed the healthcare landscape in Nova Scotia, leading to increased attention on issues like the delivery of COVID vaccines, and more recently there was a public need for pharmacists to be able to assess and prescribe for strep throat, HIV PrEP, sinusitis, and otitis media. Government or public health priorities, such as the addition of antimicrobial prophylaxis in special circumstances. Pharmacy professionals themselves frequently raise issues for our consideration, which can prompt a review of existing standards and policies. For instance, the logging policy, which is currently under review, the recently updated library policy, and the standards for prescribing for Lyme disease were all suggested to us by registrants. Finally, members of the public are often involved in reviewing our standards of practice and policies through their participation on council, our Equity, Diversity, and Inclusion, or EDI, advisory group, and various other committees that you can find listed on our website. So here's the brief snapshot of how some of the pharmacy practice work is implemented. As I highlighted in the previous slide, we begin by identifying an issue, such as the need for a new or updated standard or policy. In this case, OAT was in need of an update. This work is then assessed for its urgency for the public and integrated into our work plan. Typically, this process includes conducting a Canadian Pharmacy Regulatory Authorities, or PRA scan. This involves searching for what other provinces in Canada may have already implemented and their requirements or outcomes. In some cases, an international scan is also necessary, especially since Nova Scotia is leading on certain areas of scope. If the work is deemed relevant, a working group of pharmacists and technicians is established to assist in the drafting process. They are responsible for developing the framework of what should be included in the draft before it's presented to council for approval. Your help in this part of the work is crucial, so please consider putting your name forward for these working groups. For those who might not know, this information is available on the NSCP website, but council is currently comprised of 7 pharmacists, 1 technician, and 4 members of the public. They are responsible for making decisions regarding our work and approving any documents that we publish. After council approves the draft, we send it out for broad consultation. You may have noticed these consultation requests in your email inbox. This process is vital since working groups typically consist of about 5 to 6 pharmacists, and there are aspects that may have been overlooked or require adjustments. Consultations may also happen with the Pharmacy Association, the College of Physicians and Surgeons, the College of Nursing, the EDI Committee, and other interested parties. In this case, these standards went through all of these groups, as well as people who use drugs and the Nova Scotia Health Opioid Recovery Program group. Any changes identified in the consultations are then incorporated into the draft before it's presented back to Council for final approval to be released and posted on the website. I know that was quick, but hopefully that brief overview helps with some understanding of how our work is done and perhaps may interest some of you in participating in the process of future work. I hope that you'll find the upcoming presentation informative and valuable to your practice. And if you are interested in participating in working groups or have any outstanding questions regarding the standards of practice, please reach out to me via email at practicequestions@nspharmacists.ca. I'll now hand it over to Alex.
My name is Alex. I am a community pharmacist and the Bloom Program Coordinator for Nova Scotia Health. I am also the Nova Scotia College of Pharmacists representative for the Nova Scotia Prescription Monitoring Program Practice Review Committee and a mentor for the Atlantic Mentorship Network Pain and Addiction. In addition, I was part of the working group that helped develop these new standards with the NSCP. My community pharmacy practice has been focused in urban community settings, most recently working out of the dispensary in the Overlook, a harm reduction and peer-supported housing project. I am passionate about care work, harm reduction, education, collaboration, and health equity. These slides were co-created with Ella Kim, a Dalhousie PharmD student, and I have added some content and reflection from my personal experience to highlight some of the updates. I have received a fee for my work on this presentation, and this module has been accredited for 1 CEU by Dalhousie Continuing Pharmacy Education. A certificate of completion can be accessed by completing a short survey using the link in the video description. At the end of this presentation, there should be clarity around why the standards were updated and what was changed, and you should be able to find and use the updated resources list as needed in practice. Let's start with why the standards were updated. Here are a few reasons. They were primarily based on the now retired Methadone Maintenance Treatment Handbook from the College of Physicians and Surgeons of Nova Scotia. They also needed to be updated to ensure that they remained in line with the emerging treatment options across Canada. Plus, in 2020, Health Canada's Section 56 exemption enabled pharmacists to renew, adapt, transfer, and deliver CDSA drugs, and the standards were amended at that time to incorporate those changes. Practice is changing rapidly, and just like any other medication dispensed in your pharmacy, clinical information should be sought from recent evidence, such as clinical practice guidelines, rather than from the standards of practice. Finally, the previous standards were more prescriptive rather than outcome-based. The new standards allow for more professional clinical judgment, which aligns with the current landscape and the increased scope of practice. Now let's look at how to navigate the standards. The sections are similar to the past version, so navigation should remain the same. Although it's very relevant for all areas of pharmacy practice, you will now find a concept section that should be kept in mind when providing treatment of opioid use disorder. The standards themselves are organized into 3 sections. 1, competencies, ethics, and professional responsibilities. 2, communication and collaboration. And 3, provision of therapy. As with other standards, the appendices then have further details on how to achieve the required outcomes. The resource section includes information about and links to recently updated clinical practice guidelines and references, in addition to several local resources. It's important to note that these are current at the time of writing. Stay up to date so that your own knowledge and practice remains current over time. The following slides will highlight some key points and changes that were made to the standards of practice, and then at the end I will go through some references as well as forms that may, but don't have to be, used to facilitate your documentation processes. You may have noticed a change in title from Opioid Agonist Maintenance Treatment Services to Drug Therapy for the Treatment of Opioid Use Disorder. This acknowledges the other clinical pieces of treatment for opioid use disorder. Drug therapy now includes, in addition to methadone and sublingual or buccal buprenorphine/naloxone, different types of medications which are increasingly more common, such as extended-release abdominal subcutaneous injectable buprenorphine, also known as long-acting injectable buprenorphine, and slow-release oral morphine. For reference, buprenorphine/naloxone is also known by trade name Suboxone. Long-acting injectable buprenorphine is also known by trade name Sublocade, and the 24-hour slow-release oral morphine is also known by trade name Cadian. I will not be referring to these by their trade names moving forward. I will refer to long-acting injectable buprenorphine as LAIB and slow-release oral morphine as SROM. Okay, so there are 3 things that I want to briefly go over that are not included in these standards. These standards do not apply to opioids commonly used in opioid agonist therapy when they are being prescribed for chronic pain in people with no history of opioid use disorder. For example, methadone used for chronic pain in populations without a co-occurring opioid use disorder. It's important to always understand and therapeutically evaluate medication appropriateness, including being aware of and documenting its indication. As I mentioned previously, clinical practice guidelines and resources on opioid agonist therapy are now widely published and are more appropriate sources for up-to-date practice information. Therefore, clinical information is not included in this document. There are, however, several updated references included at the end. As new evidence and best practice guidelines continue to evolve, practitioners are expected to keep up to date as part of our continuing professional education, as we do for all other medications. Safer supply is also not mentioned. As you may be aware, the provision of safer supply has been increasing in Nova Scotia. To clarify, when I say safer supply, I am talking about prescribing a pharmaceutical-grade medication as an alternative to the unregulated supply to people who use drugs who are at high risk of experiencing harms related to substance use. While these standards do not speak to safer supply, they also do not preclude any healthcare provider from providing this option. Research and evaluation of prescribed safer supply is ongoing. When you encounter these prescriptions in practice, open communication with the patient and prescriber is encouraged. More information on safer supply can be found in the Doctors Nova Scotia Harm Reduction Position Paper, as well as emerging evidence and protocols available from various other jurisdictions. The new concepts section is primarily based on the 2021 NSCP Harm Reduction Practice Policy. It further describes issues specific to the treatment of opioid use disorder and will be discussed in the next few slides. I want to highlight this section because I feel tackling bias, stigma, and discrimination is an important piece of care work, and thus an important addition to these standards. Providing non-judgmental care is vital, regardless of the type of service being offered in the pharmacy. We are all, as people and health practitioners, responsible for reflecting on how our words and actions impact others, for learning, acknowledging, and shifting what our explicit and implicit biases are, and for creating and maintaining a safe and supportive environment for our patients and our colleagues. We know that stigmatizing interactions are a barrier to care. Inclusive, empathic, and compassionate care can support people to feel comfortable, build trusting relationships, and get the care they are seeking. In our formal training, many of us lacked education around principles of health equity, including understandings of ADIRA, or equity, diversity, inclusion, reconciliation, and accessibility, AREO, or anti-racism and anti-oppression, and cultural competency and cultural humility. There are many resources available regarding these concepts. A good place to start is the PANS resource section. Many courses and webinars can also be used toward your continuing education credits. This is a brief list of other helpful resources that I have used and wanted to share with you. The links for these are provided to you in the video description and include resources regarding health equity through an ADIRA and AREO lens, trauma-informed care, and ways to better support and care for specific patient populations. The concept of continued substance use may not be familiar to everyone. Recurrent or continued use can occur at any time during treatment. OAT is a harm reduction strategy that may or may not have abstinence as the singular goal, depending on the needs of the individual and where they are in their own personal journey. To further clarify this, abstinence may be desired by some, and safer or reduced unprescribed opioid use may be the desire or goal of others. Individuals are often reluctant to discuss their ongoing substance use out of fear that it may impact their treatment. Holistic and non-judgmental care should continue to be provided during this time. We can take this opportunity to discuss patient needs in collaboration with the patient and the prescriber or treatment team, including possible treatment modifications such as reassessing dose and/or OAT medication. We can also educate on and support other harm reduction strategies, including the distribution of harm reduction items such as take-home naloxone kits and sterile consumption supplies. We can also partner with and refer to our local harm reduction or outreach organizations. More information on these can be found in the resource section. In the Central and Western Zone, this would be Mainline. In the Eastern Zone, the Ally Center, and in the Northern Zone, Northern Healthy Connections. In addition to continued use, I also want to mention urine drug screening or urine drug testing. To help me with this, here is a quote from the BCCSU guidelines. Emphasize and ensure that patients understand that urine drug screening is performed for all patients prescribed OAT and that the results will not be used punitively or as sole grounds to discontinue treatment, but may be used to inform changes to their clinical management. Urine drug testing is a tool that can be used to detect substances consumed by the patient, including OAT, as well as unregulated or unprescribed substances and other prescribed medications. This can be used to optimize treatment and for patient safety. For example, consecutive positive tests for the prescribed OAT and negative tests for unexpected substances would suggest that the patient is taking their OAT and not taking anything that we don't know about. Negative tests for the prescribed OAT and positive tests for unexpected substances would indicate that the patient potentially is not taking their OAT and is taking things that we are not aware of. This would indicate a need for the prescribing team to have a conversation with the patient to understand what is happening and potentially adjust therapy. To relate back to the previous slide, if an individual was continuing unprescribed substance use, we would expect to see the unprescribed substance or substances along with confirmation of ingestion of the prescribed OAT. Patients may be reluctant to get a UDT or to discuss their ongoing substance use out of concern for its impact on their continued treatment. Fostering an open dialogue, free from judgment, will help encourage patients to be honest about their continued substance use. Language such as clean and dirty is stigmatizing, and instead terms such as unexpected results is preferable. BCCSU has an educational document called Urine Drug Testing in Patients Prescribed Opioid Agonist Treatment, which is included in the links in the module description. I think this is an excellent resource for further reading on the topic. Random pill counts, bottle counts, or blister packing may also be requested to be communicated by or performed by the pharmacy. Keep in mind that these can also be initiated by the pharmacist themselves as risk mitigation tools. As with any other type of therapy, it is important to include the patient in the decision-making and treatment process. In person-centered care, decision-making is shared. Incorporating person-centered approaches into the clinical management of substance use disorders can improve retention in care, treatment satisfaction, and health outcomes because it engages and empowers individuals as agents and experts in their own care. In this model, the driving force behind healthcare decisions is not only the patient's specific health needs, but also their desired health outcomes. A person-centered care plan involves co-creating a care plan with the patient, their supports, and the health team. Okay, now for the updates to the standards themselves. It is important to highlight that while the content of the standards has changed, the expected outcomes have essentially remained the same as the previous version. Personally, I feel these standards, which are half the length of the past ones, give both clarity as well as space for clinical judgment and direction toward the most current available evidence, much of which is now listed in the resources. If you are already providing this service and meeting the current OAT standards, you are likely doing so safely and thus already meeting these standards of practice as well. You may notice that the language has changed to support the expanding scope of pharmacists. This enables more professional judgment in certain situations. The standards that are truly new will be highlighted in the next few slides. Here are some examples of the new standards. I will briefly outline and explain them and their rationale. The way that a pharmacy practitioner views and treats an individual can either impede or support their recovery. Standard 1.12 states, respectful, non-stigmatizing verbal and nonverbal communication is to be used by all employees of the pharmacy. This includes pharmacists, pharmacy technicians, and pharmacy assistants. Standard 1.3 states that managers are responsible for providing access to educational resources so that all pharmacy staff are able to maintain a patient care environment that is anti-discriminatory and is culturally safe. I have already reviewed some of the resources that can support this in past slides. While the standards of practice apply to pharmacy staff, all of the people that work in your store and that interact with customers have a role to play in helping to create a safe and welcoming environment. Consider collaborating with the front store manager or discussing this topic at a staff meeting. Try to ensure that a safety culture and value system has been established in your pharmacy and that all new employees are oriented to this. Standard 1.5 is new and has a corresponding updated section in Appendix C. It states, pharmacy managers ensure all pharmacy personnel involved in the preparation and distribution of OAT understand their assigned roles and responsibilities. The pharmacist working group identified the need to enable pharmacy assistants to witness dosing, but it is very important that the assistant receives training and understands their role, responsibilities, and limitations. Pharmacy managers are responsible for ensuring that all staff involved in the preparation and distribution of oat have received appropriate training, have the necessary knowledge and skills to take on the activity, and understand what they can and cannot do. The dispensing pharmacist is always going to be responsible for assessing the patient to ensure that it is safe and appropriate to dose. The standards state that at a minimum, this involves observing and speaking or communicating with the patient. The pharmacist or pharmacy technician always needs to do a technical check of the dose at the time of self-administration, confirm dose accuracy and date and time of last dose before another pharmacy team member can give the patient their dose for witness self-administration. Just to be clear, a pharmacy assistant can only witness the ingestion of a dose after training and after these assessments are made by the pharmacist. Standard 3.7 speaks to pharmacists having to assess a patient to be satisfied that it is safe to provide them with their dose. This standard is not new, but I wanted to go over a few key points. Most of the time you will know the patient, but if not, for example, they are new or guest dosing, or you are working relief at an unfamiliar location, the first step in this assessment is to ensure that you have the correct patient. In thinking about this identification, it may not always be as simple as asking for their driver's license or photo identification. For patients without an ID, things which may be useful are photos taken in the pharmacy and put on their file, a fingerprint identifier in the case of a meth measure machine. If patients do have a photo ID, a photocopy of the ID initially presented may also be useful to keep on file. After this identification occurs, we need to clinically assess the patient to ensure that it is appropriate to dose. Easily accessible information and clear documentation can help facilitate ease of dosing and patient care, especially when a pharmacist may be less familiar with a patient, like a casual or relief pharmacist or somebody new to your practice. As pharmacists, we assess that the correct person is safe to receive their dose. This assessment can be assisted by using a patient assessment tool, if that's helpful for you. An example tool is given in the appendices, and I'll review it on the next slide. Like many pharmacists, I have had to withhold or delay dosing after assessment due to sedation and intoxication. In one circumstance, I asked the patient to come back later in the day for reassessment for dosing. In another circumstance, where a patient was presenting much differently than their normal, I called the clinic to discuss it. In that case, the prescribing team ended up wanting to see the patient that morning. Appendix C states that any concerns identified during the assessment are managed and documented as part of the patient record and communicated to the prescriber if applicable. There is no mandatory incident report sheet. We can use the form provided at the end of the standards of practice, which is seen here, or we can use the fax reauthorization function if that's easier in your workflow. So on this slide, here are some examples of documentation that could be communicated to prescribers. You can see that I filled this out just using different versions of my own name. So on the left, option 1, the notification date is the 6th, what pharmacy it's coming from, my phone and fax number, the patient's name, date of birth, health card number, what treatment we're talking about, so both the medication and the strength, the description of what happened, so the dose was withheld, and then under details I say, Al presented as intoxicated during assessment before methadone at 9:37 a.m. with slurred speech and uncoordinated gait. Their pupils were reactive, their respiration rate was normal or above 12. I withheld their dose and asked them to return in a few hours when they felt able to dose safely. They returned at 2:30 p.m., were assessed, and received their DWI or daily witness ingestion dose of 75 milligrams of methadone. In the second one here, you can see that I sent it the 5th and the incident happened the 5th. So sometimes I'll be able to send it at the end of the day. Sometimes I'll send it the morning after the day, depending on what my workflow is like and the expectations of the clinic. So it says Al presented as intoxicated during assessment before methadone at 9:37 a.m. with slurred speech and uncoordinated gait. Their pupils were reactive, their respiration rate was normal, above 12. I withheld their dose and asked them to return in a few hours when they felt able to dose safely. They did not return and missed their dose today, August 5th, 2024. And then I sign off on it. If I had any other information, for example, I called the patient, got in touch with them, reminded them that we closed an hour, or I called the patient, didn't get in touch with them, I would just add that on the bottom of the form there. Here is the example that I mentioned of a patient assessment tool. This one is found in the standards resource section. We can use this for our own assessment and documentation purposes, as well as to guide communication with the prescriber if needed. You can see that I've highlighted the areas corresponding with my assessment on the last slide. So I'm looking at speech, coordination, cognitive signs, level of consciousness, and physical signs. So again, this isn't set in stone. It's something that can help guide your assessment and communication. The main point for me is that if I feel like it's unsafe to add OAT at the time, then I will not. I'll ask the patient to come back and I will contact the prescriber letting them know. While these new standards both enable and require the increased reliance on professional judgment, Standards 3.11 to 3.13 highlight the requirements for communicating with other practitioners within the circle of care to ensure continuity of care and patient safety. 3.11 states that the pharmacy has to communicate with members of the patient's care team when necessary to manage patient care. So if your pharmacy has shorter hours on weekends or holidays, it may be helpful to proactively troubleshoot with the prescribing team before the day comes. Or if somebody doses at your pharmacy multiple times per day, have a conversation about what shorter days look like. Do they get a carry dose on shorter shift days? If not, what is the minimum spacing required between witness doses if they have more than one witness dose per day? At the beginning of a patient's treatment, I try to establish an agreed upon communication and collaboration plan, including when and how to connect and expectations around medication monitoring. This could include who and how to contact after hours in case of emergency, if needed, as well as when the prescribing team can expect to receive misdosed information. 3.12 states, pharmacists need to notify prescribers about missed doses as soon as possible. Missed doses are a strong indicator of how stable a patient is and helps the care team in their assessment and planning. Standard 3.13 speaks to notifying the patient's OAT provider as soon as possible when the pharmacist extends an OAT prescription. I will talk about this on the next slide. Okay, so I'm just going to move over to the prescribing standards for a bit here. Standards of practice prescribing drugs Appendix H, so under prescriber not available. Pharmacists should make every effort to contact either the patient's regular prescriber or another prescriber covering for the patient's prescriber before they prescribe for the patient. If a prescriber is not available to provide a written, faxed, or verbal order, a pharmacist may prescribe to extend a prescription for a patient whose dose is stabilized. Prescriptions must be written with the already established dispensing and witness dosing schedule and may be prescribed for up to a maximum of 14 days. So, in addition to the examples I provided on the last slide, the NSCP continues to receive reports from physicians who have not been notified when pharmacists renew or adapt prescriptions for OAT for a shared patient. It is critical for the safety of the patient that these prescribing activities are communicated, and that this is done in a timely manner. Like the previous OAT standards, these also do not speak to prescribing. You still need to refer to the prescribing standards for the details on those requirements, which is what's seen on this slide here. The CDSA section of the prescribing standards, or Appendix H, still applies to OAT when we are providing the service to our patients. The prescribing standards also say, pharmacists should not prescribe for a patient whose dose has not been stabilized. However, it is important that patients do not go without their dose. As such, in the rare event that not prescribing would result in the patient having an interruption in therapy, pharmacists should prescribe a limited supply and must not increase the patient's dose. And under adapting an OAT prescription, pharmacists may prescribe to adapt a prescription to reduce a dose as required in the event of a missed dose or doses. The dose must be reduced in accordance with the established standard of care provided by primary care providers or specialists and aligned with best practice treatment evidence supported by clinical experts. So in the circumstance where not prescribing would result in an interruption in therapy and the potential harms associated with this, the standards say limited supply. For me personally, I have prescribed up to 3 days if I assessed the patient and felt like it was the right decision to get them through a weekend. So for example, I have a methadone patient who is titrating back up because they had 4 missed doses, but they're not yet at a stable dose. I have chosen to prescribe over the weekend at their last dose. Let's say they dosed on Friday, prescription ran out on Friday. I can't get a hold of any clinician. They feel stable and good at their dose. They were going to titrate up. They were going to continue their titration, and I cannot legally continue it, but I can keep them on their last dose if I feel like it is appropriate and safe. So I like to remember that choosing not to prescribe is a decision on its own that can impact the patient. In situations, I see 3 potential decisions: prescribing the same dose, prescribing a reduced dose, and not prescribing. I have chosen all of these options at different times, depending on the circumstance. Another example of Standard 3.13, notify patient's OAT provider without delay in instances where the pharmacist extends an OAT prescription for the patient, could be an adaptation which may be needed if somebody missed their methadone for 3 to 4 days. This scenario combines the OAT standards with the prescribing standards. I'm saying 3 to 4 days because different guidelines use more conservative or more liberal misdosing strategies. It may be helpful to have a conversation with OAT prescribers in your area to confirm which guidelines they are using, as this may help guide your misdosing strategy. As a parallel, this is very similar to many other situations in pharmacy where we may find varying guidelines. For example, slight differences in guidance from various resources for dosing in renal insufficiency or medication use in pregnancy or lactation. Here is an example using the CAMH guidelines. If somebody on a stable methadone dose missed 1 to 2 doses, we would not reduce the dose unless there are concerns about loss of tolerance or adverse effects. In this case, I just notify the prescriber as usual about the misses, but don't change the dose. Then if somebody missed 3 doses, and again, it could be 3 or 4 depending on what guidelines you're using, we could decrease the dose by 50% or decrease to the initial starting dose if we had no concerns regarding continuation of therapy. And I say decrease to the initial starting dose because let's take the example of somebody starting on 30 milligrams, having stabilized on 40 milligrams, and then missing 4 doses. We wouldn't drop them 50% generally to 20 milligrams. We would generally drop them back to their starting dose of 30 milligrams. I always attempt to contact the prescriber or prescribing team, and the missed dose reports also notify the prescriber that somebody may be approaching having to restart. I also try to ensure that I'm able to contact OAT prescribers I work with outside of normal business hours. However, if the prescriber is not available, I would weigh the risks and benefits of choosing to provide a prescription of a decreased dose versus choosing to provide nothing. Either way, the prescribing team has to be notified. It is also important to note that once we prescribe for a decreased dose, we cannot increase it again due to CDSA restrictions. So similar to the last slide where I couldn't continue someone's titration, but I could continue them at the same dose. Once the dose decreases, we again can't increase it for CDSA medications. So this prescription would be a new short-term prescription overriding the last canceled prescription. And the prescription would be issued by me or in my name. The regular prescriber would need to write a new prescription to titrate back up to the patient's effective dose. To reiterate, I really do try to get patients to see or call or touch base with prescribers in this situation whenever possible. But sometimes it's not possible. And again, we want to balance the risk of continuing medication versus the risk of being unmedicated. Standard 1.0 states, pharmacists maintain their competence to provide OAT, including routinely assessing their competence and the need to undertake continuing education. While this isn't new, it's still valuable to point out that we, as pharmacy practitioners, have a professional obligation to ensure that we remain current in our knowledge. This is very important for OAT, given the evolving treatment guidelines across Canada right now. Similar to diabetes management over the past decade, a lot has changed since many of us were in school, so we've had to keep up using various methods of learning. Each pharmacy practitioner should routinely assess knowledge and competence in all aspects of their practice to ensure it's aligned with the current guidelines. As an example of the need for this, the NSCP has received calls from pharmacists regarding physicians wanting to prescribe longer durations of buprenorphine naloxone, where the pharmacist had not heard of this and thought that they weren't permitted to do so. This is a change in practice over the past few years and follows updated practice guidelines. Newer guidelines are much less restrictive around buprenorphine naloxone dispensing frequency, and this will likely be reflected by increased take-home doses and longer dosing intervals once initiated on treatment. Like anyone else, I've been surprised or unsure about shifts in practice, and in situations like that, I typically consult clinical practice guidelines, review research, discuss with colleagues. If I'm still unsure about applicability to the patient, I consult the prescriber to confirm. For example, did you mean to write 6 carries with 1 witness dose? I haven't seen this in practice yet with a patient new to treatment, and I ask about the shift in practice to help determine my potential knowledge gaps and inform my decision-making process. Standard 3.4 states, confirm the need for witness ingestion if it is not indicated on the prescription or is not known. This new standard is another necessary update due to shift in practice. It is important to always confirm with the prescriber whether witness ingestion is required if it is not indicated on the prescription and what the dispensing frequency or take-home dose quantity is. This may seem obvious, but with recent changes in guidelines, it's important to clarify. For example, DWI or daily witness ingestion may not be written on a prescription accidentally, or it could not be there intentionally. In my practice, I usually find it says something like, dispense weekly on Monday, witness first dose, but errors are made. if you aren't sure, it's crucial to avoid making assumptions and check with a prescriber before dispensing. Similarly, if a prescription has an unexpected change that doesn't make sense, always confirm with the prescriber. As practice shifts to less restrictive dosing frequency, this will likely be mirrored in some of your prescriptions. For example, as mentioned earlier, longer dosing intervals, quicker transition to take-home doses, and potentially take-home doses immediately for buprenorphine naloxone. If you are unsure, again, please call the prescriber to discuss and document any details on the patient file as reference for that prescription and for other pharmacists that might be working at your location. As you can see on this slide, Appendix C states, doses are provided in person and are not released to others except in exceptional circumstances. Most often, there will have been some prior communication about this with the prescriber. There may be instances where pharmacists need to use professional judgment to determine when a circumstance is truly exceptional and balance the benefits and risk of releasing doses to individuals other than the patient. I have not personally run into this, except in a couple cases where I dispensed to another regulated healthcare professional who was part of the prescribing team who delivered and witnessed a dose. Appendix C also states, determine how prescriptions for SRAM are to be administered. For example, are capsules swallowed whole? Are they opened and the beads put in a cup, which is followed by water? Are they opened and the beads put into applesauce or pudding and then followed by water? Since there isn't an agreed upon standard of care for SRAM ingestion across Canadian guidelines, it is important that if it's not written on the prescription, to ensure that you know how the prescriber is expecting it to be administered. Moving on to another update, 3.4.1, pharmacists dispense buprenorphine extended release injection in accordance with the manufacturer's requirements and do not dispense it directly to the patient. LAIB is becoming more prevalent in Nova Scotia, and 3 important points about this medication are: 1. Long-acting injectable buprenorphine must be a direct handover or delivery to the administering clinic if it is not administered on-site. It cannot be given directly to the patient to bring to the clinic. 2. LAIB administration can only be performed after training has been completed. 3. It is a controlled distribution program with access to purchasing medication only through the company. There is now a brand new section which speaks to the termination of a patient-pharmacy relationship. The NSCP frequently gets calls on what to do when considering this for an outpatient. The considerations remain the same as to any other patient in your pharmacy. While these or other standards do not prevent you from terminating a patient relationship, a decision to do this can have a profound impact on the patient and their access to care. As with any decision made in the pharmacy that can impact patient care, it should be done in accordance with the Code of Ethics. I will highlight the line that reads, registrants continue to provide services to their patient until the services are no longer required or wanted, until another provider has assumed responsibility for the patient, or until the registrant has provided reasonable notice of termination of the relationship. I suggest that we think about the situation carefully, as I would with any other patient I'm considering terminating a relationship with. I think about if I've had a discussion with the patient, if I've had a discussion with the prescriber, was this a one-time issue? Is there documentation of past issues? Is there a pharmacy across the street that they are able to go to, or am I the only pharmacy for 30 minutes? These factors may all impact your decision. In the end, I like to make sure that I have fully reflected on and documented my rationale for this decision if I proceed. Now moving on to take-home doses. As I mentioned earlier, there have been changes to the recommended duration for take-home doses in recent clinical practice guidelines. The general recommendations are included in the standards. However, professional judgment can be used to fill prescriptions for other durations. For example, if a patient has a prescription for methadone with a dispensing interval of 7 days, but they have recently lost their ability to store the medication safely and securely, the pharmacist can make professional judgment that it is unsafe to provide the full 7 days. They can adapt the prescription to a lower quantity, document the rationale for the decision, and notify the prescriber as soon as possible. Or we could get a prescription for buprenorphine naloxone for a 20-day carry, so 3 weeks overall. You chat with the patient and they say they are going on vacation for 3 weeks. You know that through the prescriber that the patient has been stable. Although the standards suggest a dispensing interval of 7 to 14 days, the pharmacist can make a professional judgment that dispensing the 21 days is appropriate. The pharmacist in this circumstance can dispense the prescription as written and documents the conversation with the patient and prescriber. I do want to mention that we may not increase the dosing interval. So if we know someone's going on vacation, then they typically pick up once a week. We cannot increase that for 2 weeks if they're going away for 2 weeks. We can share information with the prescriber, so send them a fax, letting them know, ask the patient to be in touch with the prescriber, but we are not allowed to increase the amount of days that a patient carries. Patient education for take-home doses remains the same as before. Before releasing take-home doses, pharmacists make sure that patients are educated and understand that medication should be stored securely. For example, in a locked box in the refrigerator or in a locked cabinet. The standards of practice don't require lock boxes. However, if something's stored in the fridge, as methadone is, that's often the only safe way to store it. I recommend thinking about what works for your pharmacy team, the public, which could include family members or roommates of the patient, and your patients, as well as ensuring that you are on the same page as your prescribing team and that there is a mutual understanding of what is happening in the pharmacy. In my experience, prescribers are happy to have these conversations. For example, does this prescriber believe that I ensure everybody has a lockbox? Do they believe that people bring their lockbox in every time? Do they believe that bottles are brought back to the pharmacy? Personally, I do ask patients to bring their bottles back, but I like to have a conversation with the prescribing team. For example, do I still dispense a week if they haven't brought their bottles back and ask for them next time? Do I use tamper-proof caps when I dispense carries so that I can do a proper bottle check? I believe that it is important to know what prescribers' expectations are and have open conversations to determine practice processes. Finally, the prescriber or pharmacist might decide that it is necessary to decrease or temporarily discontinue take-home doses. This can be discouraging for the patient. Opioid use disorder is a chronic and potentially recurring condition, and the continued support and encouragement by healthcare providers may help patients continue therapy or return to it in the future. Pharmacy practitioners play a critical role during these times and should avoid stigmatizing language and behaviors. We want to avoid contributing to the patient avoiding healthcare due to the way they've been treated in the past. We have the opportunity to contribute to a safe environment where the patient feels like they can show up honestly and get the care that they are seeking. Now I want to take a little time to talk about beyond use dates. There has been a lot of discussion about this since the standards were released. Although nothing about the stability and sterility of commercially available methadone preparations has changed, the NSCP has heard that there has been confusion on this section. All previous information in the standards that spoke to the stability of methadone compounded stock solution has been removed, as it was referencing methadone stock solution compounded from methadone powder. This is no longer used except in exceptional circumstances. It is important to clarify that NSCP cannot assign beyond use dates. Beyond use dates are assigned by looking at available literature and product monographs and using professional judgment to determine an appropriate date. Just like any mixture or product made in the pharmacy, if information on stability is unavailable or lacking, pharmacy practitioners should default to recognized standards such as USP, NAPRA, or the monograph, which suggest a maximum 14-day BUD in the fridge for non-sterile, compounded, water-containing oral formulations in the absence of stability information that is applicable to a specific drug or preparation. If this has been your practice and it's now an issue due to human resources or staffing or bottle preparation, there are a few options for you to consider as you move forward. Every point may not be feasible for all pharmacies, but hopefully one of these suggestions is one that you can incorporate into practice. 1. Ask 14-day patients to come later in the morning to allow more time. Many standards across various jurisdictions state something like, to avoid potential for mix-ups during dosing and to optimize stability and sterility of dispensed carries, diluted methadone doses should not be prepared far in advance of the anticipated date of consumption. 2. Prepare the doses in the early mornings when the pharmacy is closed to avoid rushing or interruptions. A schedule shift is a common tactic for this. For example, moving a shift to start at 8 a.m. instead of 9 a.m. 3. Training other staff members to help support preparation of diluted methadone doses. And 4. For 2-week pickups, you could pre-pour the methadone solution as usual, store it in appropriately labeled bottles, and QS the tang the day of pickup so that patients with 1 witness and 13 days carry can still receive their full prescription. When I would pre-pour methadone, I would write the patient's name, date poured, dose in milligrams, and dose in milliliters. Then, when dispensing, I would label over this as another point of confirmation. For tamper-proof caps, you can screw them on lightly without activating the tamper seal, and then fully activate the tamper seal when you add the tang. Adjusting the day's supply for reasons unrelated to the patient can really disrupt integral elements of patient care and treatment. The last update that I want to highlight is 1.8. The pharmacy has appropriate references. In addition to opioid agonist maintenance therapy, a pharmacist's guide to methadone and buprenorphine for opioid use disorder, pharmacies must also have access to opioid agonist therapy, a synthesis of Canadian guidelines for treating opioid use disorder. This document is easily accessible for free online on the CAMH website. In addition to the CAMH synthesis, the resource section at the end of the standards has been updated with other recent practice guidelines, educational support programs, and other generally applicable information. Just remember that this is not a living document. It is up to date at the time published. Some of the information I mentioned in this module may be new to your practice. BCCSU speaks to things such as changes in dosing and titration or initiation induction, simplified protocols for missed doses, and less restrictive take-home dosing considerations. CAMH OUD guideline lists standards of care and recommendations for different forms of OAT, considering different populations and comorbidities. Medify has useful resources on subjects such as SROM and various carry principles. I know there is a lot out there, and I personally find videos or podcasts helpful to review or integrate information from guidelines. For example, BCCSU has videos available to help review their new guidelines, including one called Changes to the Opioid Use Disorder Guidelines and What Pharmacists Need to Know, which I have found very useful to help access and integrate key points quickly. Wrapping things up here, any clinical questions you may have regarding drug treatment of opioid use disorder can be directed to the Addiction Medicine Consult Service. They are an excellent resource and are very happy to speak to pharmacists regarding questions surrounding opioid agonist therapy. This service provides quick addiction medicine consultant advice to community pharmacists, physicians, and nurse practitioners. This slide contains some more in-depth information regarding what services are and what services are not provided by the AMCS. These physician consultants are OAT prescribers in Nova Scotia that you may already be familiar with. If you have to leave a message, you can likely expect a call within 2 hours during working hours or the next business day if calling after working hours. To end the review, there are templates available to help meet the documentation requirements in the standards of practice, but other methods can be used. These are here for your convenience, but are not mandatory. I'm going to highlight 2 of the forms here. I find this OAT, DWI, and take-home log useful, which is on the left, as it has information such as total days supply remaining, which can help us easily remind the patient when they need to revisit with their prescriber, UDS notification date, and a spot for signing off on both the assessment of the patient and the witnessing of the patient if they're ingesting their dose at the pharmacy. This sheet is to be filled out before and when dosing the patient. There have been errors reported where a dosing error was caught when the sheet was completed, but the sheet was completed after the patient had left and already ingested the dose. Using this sheet correctly allows us to easily confirm, for example, quantity of last dose and day and time of last dose. It's always safest to ask the patient, what is your dose versus are you on this dose, due to factors such as confirmation bias. Errors have occurred due to this as well, where the pharmacist asked and the patient responded yes to the wrong dose. And then on the right, you'll see the opioid agonist treatment incident form, which I used earlier in the presentation. This can also make notification easier. For example, you could save these forms with the pharmacy name, phone, and fax auto-populated on the desktop of one of your work computers. You will all recognize this dose compounding log, but there is a new addition in the top right corner. It's a note to remind practitioners that commercially available stock solution bottles often contain an amount of methadone that's different than what the label indicates. It's usually a little bit more. Your pharmacy should already have a process in place to ensure that this discrepancy is identified and accounted for as part of the perpetual inventory management. For example, pouring the newly opened methadone bottle into a graduated cylinder to confirm the quantity and changing the inventory if the quantity is different than expected before proceeding to use that bottle. There have been numerous errors in Nova Scotia where the patient received the wrong dose. These may have been prevented by completing this form appropriately while preparing the dose and confirming inventory. I will explain this further on the next slide. Before ending this presentation, I'd like to talk about some of the most common examples of errors related to OAT that have happened in Nova Scotia. The first is, as mentioned a couple slides ago, if staff fill out the log after the patient leaves the store. The second is not clearly asking the patient what their dose is. So, for example, when the pharmacist asks the patient, oh, is 80 the correct dose? Are you on 80? Instead of saying, what is your dose? then you can feed into the elements of confirmation bias. The third and fourth point have to do with calculations not being documented or checked appropriately. Ideally, methadone measuring and compounding is done without interruption and with a double check. Unfortunately, this ideal situation may not always go according to plan. I would like to reiterate something a mentor once said to me that has really helped and stuck with me. If you are uncertain for any reason about the amount of methadone in a bottle, discard it and make another one. In my opinion, it's really not worth the risk. It's easy to discard it with your CDSA liquids to be destroyed, write it up, and repour a dose. On the same note, when calculating and preparing doses, 2 people should be involved whenever possible, and calculations should be written out. Let's take the example of 14 milligrams, which is 1.4 mils of the commercially available stock solution. The calculation is so easy that many pharmacists or locations don't do it, but then there's nothing to double check if something goes wrong. For example, somebody reports increased sedation. How do you confirm that the correct dose has been compounded? There have been instances reported where staff is so used to doing 10 mils that they pour 14 mils instead of 14 milligrams or 1.4 mils, thus dosing incorrectly at 10 times the correct dose. We are all so busy in pharmacy these days, and proper calculation and documentation can help prevent simple but very serious errors like this. The fifth point, as mentioned on the last slide, when the perpetual inventory on your log and pharmacy software has not been maintained with the manufacturer overflow, and there's no way to identify a dose error. Calculating the running tally of solution remaining without cross-referencing to actual amount of inventory due to aforementioned issues with amounts in commercially available bottles is irrelevant without reconciling with your actual inventory in stock. To be clear, the amount of stock remaining on your log should match the amount of inventory in your pharmacy software plus your prepared bottles. If the extra in bottles is not being accounted for, then the inventory is perpetually wrong, which means it can be impossible to try to identify an error. For example, if somebody reports being sedated and my mind flashes to thinking I dose someone with 10 mils or 100 milligrams instead of 1 mil or 10 milligrams, I would double check my calculations and double check my inventory and compare what I am supposed to have with what I do have. The last point I want to talk about is rushing. Changes in regulations, such as being able to transfer CDSA prescriptions, has been so valuable for patients. It makes more space for flexibility and autonomy of the patient, which can allow for more connection with family and community. When I make the decision to accept any transfer, I think about a framework for decision making, the benefit and risk to the patient. Most times I have no issue accepting transfers, but there are instances I may have to refuse based on capacity to adequately prepare things. For example, near the end of the day where I am already short-staffed and struggling. In that circumstance, I'm often feeling some moral distress balancing both accessibility and desire of the patient with the feasibility and safety of the request. What I might say in that circumstance is, I don't have the capacity to do this today for you, but if you decide you would like it here tomorrow and you go to your normal pharmacy and have them call me to transfer it over after you get your dose, I will do that for you. If it's after hours and they leave a message, I'll make sure I check the machine in the morning. As pharmacists, we have to balance taking all reasonable steps to provide timely access to medications to the patient while ensuring we are working in a safe environment within our capacity. I hope that you enjoyed this presentation and that it helped your understanding of why the standards of practice were updated, understand what was changed in the standards, and be able to find and use updated resources as needed in practice. The standards were updated to help pharmacists better care for their patients by removing barriers to care that were no longer appropriate based on emerging evidence, evolving patient care standards, and knowledge of opioid use disorder and its treatment. If you have further questions regarding the standards of practice, please reach out to the NSCP Pharmacy Practice Team via email at practicequestions@nspharmacists.ca. Thank you so much.